is Dr. Nahla Afifi, the Director of the Qatar Biobank. And her topic is Qatar Biobank Management Approach and Implemented Tools Used to Adapt to the COVID-19 Crisis.
Hi, hello. I'm Dr. Nahla Afifi, Qatar Biobank Director. At first, I would like to thank the organizing committee for inviting me to present the Qatar Biobank management approach and implemented tools used to adapt to the COVID-19 crisis in Qatar. As a short introduction, Qatar Biobank was established in 2012 as a research platform to provide scientists and researchers with medical information and standardized data and quality samples to help implementation of the personalized healthcare for the benefits of people in Qatar region and worldwide. The main study initiative was for the biobank is a cohort study where we have planned for a longitudinal population-based study where we are recruiting 50,000 participants. They are, all of them are adult, either they are Qatari or long residents who lived in Qatar more than 15 years to assess and measure the influence of the lifestyle and also environmental factors in their health. Then through the years, we have more initiatives and projects nested in the biobank. We work to establish a tissue bank. We are in the final stage for cancer, breast and cancer colon, collecting samples and data with collaboration with the hospital, Hamad Hospital, and also linking our biobank data with the medical records of the participants and the clinical data through the CERNER, which is the electronic medical system in the country. And also there is a project which is the Qatar Genome Project, which is nested in the biobank for the pilot phase, where it sequences all the participants, Qatari participants recruited by the biobank. Currently, we have sequenced more than 20,000 participant whole genome sequenced. And also another initiative, which is the MRI screening. We screen for the whole body and the brains associated with the cognitive test assessment through the Cantab battery. And another study which is related to QF study, which is with collaboration of Ministry of Public Health, where we are recruiting pregnant women, second trimester, third trimester, and also the father, and follow up the baby for 5 years. So you will have the trials of this. We are currently finalizing the pilot phase, the first 500 participants, and the target is for recruiting 3,000 tribes. And of course, the new initiative, which is the COVID biorepository as a national biorepository in the biobank, which we will according as a response for the COVID crisis. Currently, as I mentioned, we have total 31,000 participants. Most of them, they are through 6 studies, and most of the average of our participant is 14 years old, and also that we have around 50% of them are female and another 50 is male. For the infrastructure of the biobank, we have a separate building facility which is fully occupied with for collecting clinical data with clinical measurements. We have a clinic information system, closed one, where we register the participants and consenting them. We have several measurements within the facility, starting from the height and weight, and also spirometry, ECG, muscle strength, bicorder, for stiffness of vessels, IDEXA for the bone density, and ultrasound, carotid ultrasound, and the retinal scan. And for another visit, we take the MRI associated with the cognitive test battery to measure the attention, the psychomotor speed, effective executive function, and episodic memory. This visit is around 3 hours. We collect blood, urine, saliva. Half of the blood we send it to the hospital where we measure 66 biomarker, and the other half we store in the biobank in 3 identical plates. It is either in -80 automation, which we have in the facility, or liquid nitrogen or remote distance storage for disaster recovery. Our labs are highly equipped lab is linked through automated. Most of our systems are automated robotic system, starting from blood fractionation, DNA and RNA extraction, DNA and RNA quantification, cDNA purification system for from the RNA extracted RNA, and also with purification, PMC, cryopreservation, and lab chip microfluid nucleic acid integration, integrity quality control, and DNA fingerprinting and gender determination, microarray Q-chip through axiom process, cryopreservation, as I mentioned, and biospecimen storage. We have the lab with the flow, also associated with the flow lab, and we have the CPT automation in class 2 safety environment associated with the processing lab. All of this, as we said, that we have the infrastructure, the clinic, the labs, and also for providing the researchers with the data and samples required per their project. We have an access project where we, through the portal, they register the request, either they have a query request or the applications, access application form. This is reviewed and then by the IRB, and once it's granted, we provide them with the data and samples. Currently, we are ISO, because we are targeting the excellency in all our processes. We are ISO accredited for QMS, quality management system, and also for ISMS since 2014, and recently we renewed our certification in 2020. As we found that we have, there are common areas in ISO 9001 to 2015 and ISMS 27000. We decided to go with integrated management system for documentation with the common areas, and also that for our lab for the Q-chip and for the axiom process is CAP accredited, extended from the hospital, and also we are seeking the ISO accreditation for the biobanking. So as we all of us know that in December 2019, the first COVID case was identified in China. In Qatar, the first case was identified in February 2020. Until that time, we are working from our facility as usual. Then in March 2020, the decision was coming from the higher management that we, with the recommendation that stop operation in the mid of March and start working from home for all facilities and institutes in Qatar Foundation. So in the response, for the growing crisis, Qatar Biobank was identified as a Qatar by the Qatar Scientific Reference and Research Task Force, SRRT, that to be the key institution to manage the design and set of COVID biorepository in the country as a national project. So as a national resource to accommodate the COVID-19 biorepository of COVID patient samples. So we worked together to submit a proposal to get the fund from the medical research center at the hospital, and this happened and get the IRB approval in April 2020, and within May 17, mid of May 2020, we started the collection, or the first collection. Then, of course, as you see that all of this activity from designing to implementation, it took around 5 weeks. We start to add, along with our recruitment, to add some modification of the proposal by either by adding a collection kit or extending the sites for collection. And this journey was successfully completed as we targeted 2,000 patients by September, mid of September, within 4 months. So what was our protocol? And at the beginning that we go for collection as it is a prospective study. Our target population was Qatari resident or long resident, or any resident in Qatar, either Qatari or any nationality, who diagnosed with COVID-19 and able to communicate either in Arabic, English, Hindi, or Urdu according to the consent available. We recruited at the main 3 COVID-19 hospitals and also the isolation centers where the moderate and mild cases were found, were allocated, were separated. And as showed that we collected from the beginning, after the consent, we collect a questionnaire. The questionnaire is the WH questionnaire, and also we collect biological samples, blood swab, endotracheal aspiration if the patient was intubated, and the residual samples if available from the virology lab. Then we have follow them, the participant, every week as long as they are in the hospital or in the isolation center. Then at 1 month, follow them. We give them an appointment to come to the biobank after 1 month, and follow them 3 months, 6 months, and also 1 year after recovery. So within, as I mentioned, that all of this establishing of the protocol took from us around 5 weeks. So to transform all our operation to facilitate the national COVID biorepository as with the high quality of service. So the IT team developed an electronic system for the data collection and specimen traceability, as we are collecting samples from different sites. And also our clinically trained staff were transferred, the nurses and the radiographer, to different healthcare facilities in order to recruit the COVID-19 biorepository. We have 12 nurses, research assistant, and radiographer. The medical review system office, our medics, and the scientific and education department, they are the leader as a project management to set the study and provide training to the staff. Communication to the participant recruiting, our communication and participant recruitment department transfers its operation to fit the needs of the COVID initial at the beginning, either they were transferring the PPE to the different sites as the storage, there is no space allocated to us. Then for booking for the follow-up and informing the site nurses and also staff, which for the follow-up either on site or once they finish the 1 month and come to the biobank for the follow-up. Of course, the research access office designed the COVID access report and also the project for purchasing the PPE and other administrative works needed. So this shows that the QBB Operation Resilience Plan that we started with the organization plan, the QBB and network, we have the capability with the network, especially with communication with the hospitals and the isolation centers. We have the best practice and guidelines. We have the targeted tools and we have the standards. Like we have the tools as I mentioned that we are ISO certified so the documentation, the way that we are following the SOPs or in the culture as the culture of excellency present within the biobank give us the ability and the flexibility for fulfilling all the requirements. What are the main challenges which we found and the lessons learned? That the continuity of operation, which is unsustainability in emerging threatening situation, so the personal safety and well-being and the maintenance of existing QBB cohort, we were not able to serve the research stakeholders, distribution of disturbance, like for the access and the biological material. We had at the time like a long pipeline of requests from researchers. They are sitting at home, they are requesting samples and data from the biobank from our cohort. Unfortunately, we have a limitation at that point, as all of this data on the clinic network and people are working from home, so our data managers and extractors, they couldn't fulfill, and we have a backlog of projects requesting data from our biobank. Also, disruption of the supply chain, because the consumables, we have challenges in the consumables, we have challenges in the PPE. But fortunately, we had some because we kept accredited, and we have some for accessing our labs. So we were lucky in this part. So as an outcome, in September 2020, we set and completing the task for recruiting from the first wave of COVID patient. We successfully recruited more than 2,000 participants from different sites, around 9 sites, different sites. Most of around 50% of them, they were male, and another 50 were female. The distribution age, as it appeared from this presentation, that most of the recruitment were between age 31 and 60. They are adult, and in spite that we thought that we will have more older patients. We have like middle-aged participants between 30 and 60 each. So the nationality, most of the recruitment, where we have around 40% were Qatari, And the distribution will represent the infection, like different 11 nationality between Indian, Filipinos, and Bangladesh, Nepali, Pakistani, Egyptian, Sudanese, and Yemeni, and other nationalities. So according from face-to-face interview, where we have a questionnaire about the WHO questionnaire about the severity and also about the signs and symptoms associated with the COVID and referral to the hospital, we have the most common cause of that they have contacted most of the participants who said yes, that they had contacted before with anyone suspected and confirmed with COVID. And a few of them, they reply that they have traveled in the last 2 weeks, at the time that there were a theory that the vaccinated people with BCG is protected, give protection, but the data represent the opposite, that there is no difference, as we have 239 participants. They indicated that they were vaccinated from the sample collected. And that's, yes, this is the second time people, they were tested for COVID before. And again, we have another question to have the symptoms related for the QC, as a question of QC for travel. The most common symptom, which was coming, that it was fever, then fatigue, and also a cough, dry cough, and the headache, which presented by the patients. We have the continuation study, as I mentioned, that we follow them on a monthly basis, and month 3, 4, 5, and 6 until 1 year. So, of course, as it's expected that the number of participants who were coming as for follow-up is declining over the year. So, our conclusion is that the implementation of the appropriate tool by Qatar Biobank and its network with other stakeholders managed to create the robust framework for an effective response to the pandemic, establishing a successful COVID-19 biorepository considering the needs of wide sector of researchers, while ensuring robust governance will minimize the impact of research specimen collection from patients and will maximize the use of the samples for multiple research projects in Qatar. And extending that we have now a new project, we extend the COVID biorepository to include recruiting of the vaccinated cohort and follow them for 1 year. So at the end, I would like to thank all the team, Qatar Biobank team, who without their efforts and honestly their dedication, we were not able to achieve this task. Thank you for your hearing, and I'm open for any question. Thank you.
Thank you, Dr. Afifi. That was an excellent talk. Very detailed and very impressive national response to a pandemic. I have one question, at least. There you are. One of your slides showed the demographics of infection, and I believe something like 40-some-odd% were, if I'm saying this correctly, Qatari citizens. Was the demographics of infection approximately the same as the demographics of the country? What I'm asking is if certain groups were more prone to infection.
No, it represents the recruitment, the number of recruitment, because most, as we go for the hospital and the acceptance of participation within the study, and also because we have multinational, So it's either the people who speak Arabic, English, or Hindi. They will be able to recruit for getting the consent. There are a lot of languages, other languages, especially within India, because most of the population were Indian, but they don't speak Hindi. So we couldn't get their consent and participate. But it was more the spread as a demographic with infection between the laborers. So that's why it wasn't representing exactly the distribution of infection.
All right, and another question. Thank you for that answer. That's it emphasizes the cross-cultural issues in a country like Qatar. Were any of the countries in the local area, were there any other efforts mounted that were as impressive as this, or even close?
Honestly, from our knowledge, it was like plans, but we didn't hear about one successfully collected this number. So even we collected in this was the first wave. We collected 2,000. We have collected in second wave another 500, and now we are vaccinated. So we continue recruiting according to the needs in the country. But for our knowledge, nobody succeeded to recruit this number. Yeah.
Well, I can understand that, certainly. We have a question from Marianne Brown. She mentioned several areas: IT, staff, communication, supply. Which of these required the most attention in resetting up the Qatar Biobanking during the pandemic?
All of them, honestly, because in the Biobank we have all of this stuff. So without the input for the IT, especially for designing the in-house collection system in Onyx, and have an access to Citrix and the lab for preparing the kit and transferring and scanning the kits and linking with the data and the questionnaire. So all the team together, and also training and recruiting, and even like the nurses, they didn't have the experience for recruiting participants from outside. Usually in the biobank, the participants come to us and they consent them. So convincing the patient to sign the consent and to collect from them the samples on site, it was a new experience. And even wearing the PPE and all to be protected, and because the safety is a priority. So it's a lot of training afternoon and many times until we accept them and send them on site. So that's why everyone was working through this pandemic. Yeah.
Had Qatar had experience with SARS-1 or MERS, and was it valuable?
Honestly, in MERS, yes, they have. As I think the first case was coming from Qatar. At that time, we have one study for following a patient who had MERS before and then they got COVID. But in general, as a biobank and with this level of involvement, this is the first time for us.
Thank you very much. I think we need to move on. Excellent presentation.
Thank you.